Hi, this is E. David Crawford, and thanks for this opportunity. I want to thank Faye Stern for putting on this meeting. It's a real shame that we can't be there in Boston. It's been a great meeting the last few years. Also like to recognize Richard Babayan, who is one of the co-chairs of this session with me. I was asked to give a keynote address on liquid diagnostics, and that's a fairly broad topic, but what I want to do is sort of set the stage first so they sort of drop into place. So, my plan is to just review very briefly some of the issues with early diagnosis of prostate cancer. And then the last part of my talk focus on different pathways where these liquid diagnostics or molecular markers really are playing a significant role. So this all sort of fits into place. So when I ask clinicians and family practitioners and others, urologists, are they satisfied with the current state of prostate cancer early detection? And most of the people, almost 100%, say no. Why do they say no? Because there's a lot of controversy, there's a lot of confusion and things like that. So let's try to get to the bottom of it and start there and build up and figure out why molecular markers play a very important role in our early detection and stratification of prostate cancer. So if we start out with PSA is a great test. It is one of the best markers in oncology. It still is. What we know is that it's a great way to detect prostate cancer. There are some problems, and that's where markers help. Also, PSA is a test that gives us a way to follow disease. And what other tumor marker do we have where you can do a simple $40 test and say somebody's failed a local therapy or that they need a biopsy or things like that and following them. But who orders PSAs most of the time? Well, we think as urologists and oncologists, we probably do. But in actuality, if you look, over 90% of PSAs are ordered by family practice and internal medicine doctors. So if you're going to start with PSA, I think it is a great test, but I look at PSA sort of as throwing out a net. We want the little fish to get away. We want to catch the big fish. And it also fits very nicely what we see in medicine. When family practice doctor, sees an elevated blood sugar, he doesn't order metformin or insulin right away. He does an A1C hemoglobin. So if you have an abnormal PSA, maybe what you ought to do in select patients are do these liquid biopsies, liquid diagnostics, or molecular markers to help us decide who to biopsy. So the next question is, what's a safe level of PSA? And we could spend 20 minutes arguing about level of cutoffs of 4, 2.5, 1.5, 10, whatever. But what we did was approach it by looking at a large group of men, 21,000, in a database where there was a lot of follow-up, the Henry Ford database. And we said, was there a PSA cutoff below which you didn't get in any trouble and above which it was sort of a gray zone or an increased risk of prostate cancer? And suffice it to say, that turned out to be about 1.5. So if your PSA is less than 1.5, you've got only a 0.5% chance of being diagnosed with a significant prostate cancer in the next 5 years. Nothing's perfect, but it's a way to start. And guess what? 90% are ordered by family practice doctors, and it's an easy way for them to remember. Okay, so what we have here, as your PSA increases, we know so does the risk of prostate cancer. We saw in African Americans that this 1.5 to 4 range, if they were in that, they're almost a 10% increase in the risk of prostate cancer compared to being below that. So PSA of 1.5 doesn't necessarily mean that you have prostate cancer. Most commonly, it's the size of the prostate or its BPH. But I view this greater than 1.5 to 4 sort of as an indication or an index of prostate health. It also, we know from studies that have been done, gives you a sort of a view of the long-term risk of prostate cancer. So I don't say we need to biopsy everybody with a PSA of 1.5. We don't need to do molecular markers. But guess what? These prostate cancer markers, PCMs I call them, really do help in determining who to biopsy. Well, one of the first arguments are, well, we have this cutoff of 1.5. we're going to be subjecting a lot of people to evaluation. Well, we answered that by looking at 400,000 PSA tests, and we found out that almost 75% of PSAs and actually 73% were less than 1.5 when the test is ordered. So 20% fall in the 1.5 to 4 range. I think a lot of us will say, okay, if it's above 4 or so, we're probably going to evaluate them. So this is the playing field right here, this group of 20%. So that's where we think informed decisions should come in and talk to these men about what to do next. So what we know is, and we published this a number of years ago, so did Klaus Wilburn from the MTOPS trial, is that as the PSA increases here, what we see is the prostate volume increases. So PSA is a good surrogate for prostate volume. So a 1.5 is probably a prostate volume of about 35. And as PSA goes up, so does the volume. So what that means is not everybody needs to get a biopsy. And here's where molecular markers come into play. So we published this, when I'm going to show you, in its earlier stages, and this article in Urology about 5 years ago. I'm going to spend the rest of my time focused on this diagram here and go through it and focus on where these liquid diagnostics and markers help us. So let's say a guy comes in, he's eligible for screening. I'm not going to get into arguments about screening 80-year-old men or 40-year-old men or things like that. I think that's the decision you have to make. But in general, somebody has a 10-year life expectancy. They're a candidate for screening. If they have strong family history, things like that, you might want to move the age up, whatever. So if you come in, you see the family practice doctor or a urologist, and your PSA is less than 1.5, you can repeat that in 5 years and then come back. So you don't need to do yearly. If it's greater than 1.5, you get a yellow light, and that's what tells us that this could be BPH. You need to evaluate for that. It could be prostate cancer, prostatitis, so forth. So what you do here is, you think it's BPH, large prostate on rectal, urinary symptoms, maybe treat that, bring the patient back in 6 months and repeat it. If you're worried about prostate cancer, we're going to do a marker. If you have somebody that comes in with a strong family history of prostate cancer, breast cancer, ovarian cancer, colorectal cancer, this is a patient where we might use liquid diagnostics to look for germline mutations and other things like that. We have Ambry's prostate next. We have Myriad's MyRisk, and in some degree, Prompt PGS, and there's other ones coming along this that looks at SNPs. If the patient you're worried about, they might have prostate cancer, do one of these tests. Select MDX is a urine test, 4K score, PHI, exosome DX, and there's a lot others. I can't go into all these in detail, but the one that I've had the most experience with has been Select MDX. If this test comes back high risk, then you proceed to a biopsy. If it comes back low risk or any of these other ones, then you go back into the loop and have the PSA repeated in a year. So high-risk patients, prostate biopsies, we could talk many different ways about doing prostate biopsies. There is sort of a direction right now towards transperineal, which we've been doing for over a decade, and doing these mapping biopsies this way. If the biopsy is positive, then it depends on, is it a low-grade cancer or high-grade cancer? If it is a low-grade cancer and you can consider active surveillance, for sure, there are candidates for Oncotype DX, Polaris, Decipher biopsy. And I also think we have pretty good evidence that these men should get some germline testing done. If it's positive, then they go through the various treatments. We have another marker here that helps us if the patient has positive margins or other things with radical called Decipher. And the last marker I want to talk about here is, what if the biopsy is negative? There was a lot of good data with MRIs and things like that. Also, a good test is Confirm MDX, and that's been studied too with MRI. And if that test is positive, it's a great place for MRI to go and perform a biopsy of the designated area. There's also a nice study that Yale Barons has done in Nijmegen, looking at using molecular markers Select MDX prior to MRI, and it fits into an algorithm to do that test and then follow with an MRI. So we're very fortunate to have a whole bunch of different liquid diagnostics out there, but I think we got to put them in their place where they go. And the goal is to find prostate cancers that need to be treated. I don't want to find patients that we're going to put on active surveillance. We got to filter those out first. So, with that, I want to say thank you, and I look forward to hearing the rest of the speakers in this section.